right, welcome back everybody to your Citations Classics shoulder and elbow edition. Today we're going to be talking about slap tears. We have a few, well actually one new face, and then we do have our whole shoulder and elbow Citations Classic team, although some people cannot be here as we have moved around. So I'm Sam. So I am now in my PGY 3 year at University at Buffalo. Brad may be able to join a little bit later, but he is now a chief at Buffalo. Joining us this time is Matt Alben. He's also a 3rd year at Buffalo. Teja is still at Harvard, but he is busy on the trauma service right now, so he'll join us for the next one. Matthew is here. He is now starting his residency, so he is an intern. Jalen is also an intern, but he is busy and unable to be here as well. And then last but not least, we have Alex Macfarlane, who will be finishing up his fellowship shortly and getting started with his attendingship. So we got a really great episode for today. We have slap tears, so without further ado, we're going to get right into it. The shoulder is oftentimes referred to as a golf ball on a T-peg. So if you think about turning the golf ball sideways, that's kind of the stability that can sometimes be had with a shoulder. And essentially the soft tissues, capsule, labrum, a bunch of other things kind of hold that in place. And oftentimes you can think of the labrum as a bumper car. So it's kind of a cushion that goes around the outside of the glenoid, and that kind of gives a cushion for the humeral head to sit in, and it helps increase some stability. The other thing to note is that the long head of the biceps goes in and inserts on the superior aspect of the labrum, which can cause issues, mainly slap tears, and that will be a lot of our discussion today. So this is kind of a representation, if you're following along on the slideshow, of the kind of a side view of the glenoid, where you have, again, the labrum, that kind of cushion around the outside, and then some illustrative labral tears. And then added in purple is the superior aspect where the biceps attaches, and that's where we characteristically get these slap tears, or superior labral anterior to posterior tears. Below it is kind of the way that we generally evaluate these. Radiographs are often normal. CT scans don't give a good look at the labrum, so this is generally diagnosed on MRI. So on the left side, there's a coronal view looking at the shoulder with the humerus on one side, and then kind of the small triangular labrum at the superior aspect of the glenoid. That is kind of a normal appearing labrum. And on the right side is, again, a different view, again, a coronal view, and you can see the white fluid. So this is probably an arthrogram where they inject dye into the shoulder joint, and you can see that that fluid is getting in between the glenoid and the actual labrum. And so you can see that labrum is detached from the glenoid, and that would be a characteristic sign for a slap tear. So with that kind of background, we'll jump into our first article, which is a classic kind of describing the different ways that slap tears can look on MRI and then arthroscopically.
Yeah, so real quick, Sam, I know you played baseball. Matt, did you play baseball too quite a bit, if I remember? No, I know you guys talk about it a lot.
It was the rest of our class.
Yeah. Do you guys know anybody that's really been treated for this? Like, has a slap repair, like, did anybody on your team at St. Bonaventure ever get a slap repair, do you know?
Nope, I had some labral degeneration and stuff like that, but nobody actually did surgery for it.
Typical classic, thrower shoulder, like, and you'll kind of see the theme through these that tends to be the case that, is it degeneration? Is it compensation? Because, the thrower shoulder is pretty amazing to get back into that external rotation. Maybe this is, something that's needed to be done. But, once you go into repair a slap, it's not exactly like, oh, you'll be back in 6 months. It's not exactly the easiest recovery, but we'll get to it. So first paper I have is the Snyder paper, Snyder classification, talk about slap lesions of the shoulder from 1990 out of Arthroscopy, or the Green Journal, at SCOE, or the Southern California Orthopaedic Institute. Honestly, coolest thing about this, probably not cool for Dr. Snyder because he probably did a review of all of these, but They reviewed 700 of these tapes of, I'm assuming might have been VHS. I don't know, CD at the time, going through this and going back through 3 years of arthroscopy and actually looking to see, when a SLAP was identified. So this was, again, 700 cases in 27 patients. Yeah, I think they really identified 27 patients through the chart and then looked at the 27 videos, nonetheless, a pretty big deal. 23 males, 4 females. Once you look at this, now you can go back to the first one. It's really just 2 slides. So when you look at it, wide range of time to surgery and the age range. With the females tending to be older, the males tend to be younger. You're talking late 20s, early 30s, but all the way up to 60. Talking people came in for 6 months of pain, and 6 years of pain. So it's kind of all over the board. The introduction talks a little bit about the physical findings. When you read that, I take that with a grain of salt too. Not that the physical exam isn't important. Certainly, my go-to is really just the speed sign. Jurgensen's I always have a little bit of trouble with, but there is a lot of data out there to suggest that the sensitivity and specificity of these bicep signs are all over the place. But so what they essentially did was they characterized these 4 tears that you see here. One, I can't tell you that I've gone into many shoulders when we're in there for a good reason and not seen a little bit of a degenerative slap tear. On MRI, you'll see that too. The photo you showed of that big honking slap tear earlier, like that's a really good one. But sometimes you'll always just see a little bit of cleavage up there of that fluid. And the curious one is like, all right, is that a little sublabel for Raymond, or is that just degenerative slap? So the funny thing about that enough though is out of the 27 patients, they only had 3 that really had that, right? So 11%, so a pretty small number. Whereas number 2 was the biggest they saw, which you get your probe up underneath there, you lift up the biceps, and you can kind of see it go under the, onto the top of that glenoid and the supraglenoid tubercle. And that biceps comes with it. You should see fibers kind of coming through there, but that biceps, you can kind of even tug on it, and you can see how the biceps wants to pull on that labrum. So again, that was 11 of them, or 41% of patients. And then, I can't tell you that I have seen, through my training, these type 3 or type 4 tears, but really just a bucket handle versus a bucket handle plus biceps attachment. So, what they did is they just excised all these or debrided all of them. So the type 3 is that bucket handle, so you just excise that rim. The biceps is still there though. And that was 33% of patients, just a lot. I mean, again, I don't see this in any large volume at all, and they saw 33% or 9 patients over a 4-year course. And then the last 4 were this type 4 tear where the biceps with the superior labrum actually come and tear. I'm curious, is it a really different population, big population, more throwers out there in Southern California, so they're ripping on their shoulders a lot more. I think again, this stuff gets quoted in the literature quite a bit. I don't know if it's totally representative of a full population, but it's the first study to really sort of describe this stuff. It's also a question of curious. I could probably tell you that again, type 1s, you look at a labrum and it looks like type 1 if it's over the age of like 40. They do note that later on in their studies too that they start to talk about repairing, and you can go to the next slide which shows the rest of their findings. So associated pathology, right? Again, here's the rundown. Again, that 41% of patients having type 2 tears, that's the one you really see, and that's probably the one that most people are going to run into in their training and shoulder practice, are those type 2 slap tears. If you note, again, we'll go over it in some other studies, but those by and large are getting biceps tenodesis, not really repairs. Other stuff you're looking at, partial cuff tears, you're talking about 26%, full cuff tears, 15%. Anterior instability, which was interesting to me, was 15%. So, you're wondering, is that a slap tear as a result of a bank cart that kind of ripped around, or they're kind of connected at the end of it? Who knows? And two of those went on to get arthroscopic repair. They combine indentation fracture, which I'm presuming to be a Hill-Sachs lesion, maybe, with chondromalacia. So 15% are degenerative, or 4 of their patients were degenerative. So I assume three of the type ones were part of that humeral head chondromalacia. And then, again, 3 patients had AC arthritis, but you can find that quite easily, and anybody's been doing any overhead activity beyond that. So other stuff too that they treated at the time, labral to Piedmont, you'd assume that that's what they're doing for the majority of these, right? But only 48% of that cohort. And then open biceps tenodesis, you'd take that to be some of the patients, certainly the 4 patients who had the type 4 tears, though I'm curious what they did. Did they attempt that repair in that type 4 patient? Because there's one, that didn't get it. And then a big smattering of patients had other open treatment not otherwise specified, or 33%. So, again, it's an important study to see those, really what's the bulk. So if you look at the Snyder, the modified Snyder, I forget how many true types there are now. Stop at 4 if you really care about your well-being, because those are the big ones, right? And those are the testable ones. That's really what comes from this paper, that type 1, type 2, type 3, and type 4, and just use that graphic, right? So just degenerative biceps, degenerative labrum with the actual slap tear that we're talking about, where the biceps anchor comes off, bucket handle plus biceps, and stop there.
Great summarization of that, Alex. I mean, that was fantastic. I think 2 big things that you noted too is those MRI findings can be very hard to pick up on. The picture that I showed, again, if you're following along on the slide deck, was one of the various very obvious ones, but that is often not what is seen on MRI. And there is a ton of variability within the superior labrum, anterior labrum. I mean, you can read about a ton of different variations between the Buford's complex, sublabral foramen. So there's a lot of variability there. And then if you want to review that, and actually a really good article that I've just been reviewing as well, again, and a lot for our younger listeners, is you can find an article where it's looking at basics of reading an MRI for a shoulder, and it'll go through all of this, and they'll have great pictures in there as well. The other thing that you pointed out again is how kind of important this paper is in terms of the types, and this is kind of what's commonly cited and tested and everything like that. But it's very important to note as well that this had 11 patients, as they're saying 41%, and correct me if I'm wrong, but I think that's actually the number that's still on ortho bullets for that. This is the percentage, and I think that's probably a lot higher than 41% now.
Yeah, I saw that too, and that's exactly what I was going to say, is that those percentages certainly are true for them, but you got to really think who's going to SCOE to get their shoulder scoped in 1990 is different than who's going to your hospital to get, your practice to get their shoulder scoped. The dynamics are going to totally change. And, young laborer to single A baseball pitcher are going to be totally different demons there. And the throwers and laborers are going to have higher slap tear percentages, but I don't even know if they're going to be, up to still that, like seeing 33% with a bucket handle tear. I don't know. Brad just jumped on. Maybe I wonder if he's seen a buck handle tear. I sure haven't. He's still queuing in. We're good.
All right. Well, we'll keep going on. But next study here.
All right. For the next study, we have titled Glenoid Labral Tears, a Prospective Evaluation with MRI Imaging, MRI Arthrography, and CT Arthrography. This was done by Chahandi et al. Done in 1993, and it had almost 900 plus citations. So ultimately, the study design sought to compare MRI imaging with MRI arthrography and CT arthrography to determine the sensitivity of each technique in determining whether the labrum is detached or degenerated. So ultimately, this study had a total of 30 patients. The patients age range between 19 and 30 with a mean age of 27. And these patients had signs or symptoms of shoulder instability and or pain without identified origin. So the study went as follows. The patients first had MRI imaging, and then they went MR arthrogram. In 28 of the 30 that underwent CT arthrography, of those 30, only 28 had CT arthrography. So each patient then underwent arthroscopic or open surgery. 15 of the patients were done arthroscopically and 15 were open. Patients had recurrent anterior instability. 2 had 1 prior anterior shoulder dislocation, and 8 with shoulder pain of unknown cause. And also, it's important to note that the preoperative imaging studies were interpreted prospectively and independently from one another, and then each study was examined with 2 observers who came to consensus of the findings after reviewing the images. So the results showed that labral tears were found in 28 of the 30 patients at surgical intervention. First, the authors laid out the results of labral tears being detected. For MRI imaging, 26 of the 28 patients, or 93%, was positively detected. In MR arthrography, 27 of the 28 patients, or 96%, showed to be positive. CT arthrograms showed that 19 of the 26 patients, or 73%, were positive. So overall, there was greater sensitivity to the MRI arthrography when compared to CT arthrography. And this was statistically significant. So in terms of detached labral fragments, the MRI imaging showed that 12 of the 26 patients, or 46% of them, had positive findings. For MRI arthrography, 25 of the 26 patients, or 96%, showed positive detached labral fragments. And then for the CT arthrograms, only 13 of the 25 patients, or 52%, showed that. And then also, it's important to note that of the 4 labrum that were normal or had non-detached MRI imaging, the MRI imaging was the best at showing non-detachment. And then also, finally, they looked at labrum degeneration, and MRI imaging showed that 2 of the 18 patients positively detected that. For MRI arthrography, 10 of the 18 patients, or 56%, were positively detected. And then CT arthrograms, only 4 of the 17 patients, or 24%, were positively detected. So overall, MR arthrography was the best of the 3 imaging techniques to show the inferior part of the glenoid labrum and the inferior glenohumeral ligament. So just to round this out and state the final conclusions, the authors showed that MRI arthrography is the most sensitive than both CT arthrography or MRI imaging in the detection of abnormalities of the labrum and the associated capsular structures. They also showed that MRI arthrography was the most sensitive of the 3 techniques for detecting both detached labral fragments and labral degeneration. And then also, finally, MRI arthrography gave the best visualization of the inferior part of the labrum and the inferior glenohumeral ligament. Study is really helpful because, as clinicians, it really allows us to know which test we want to order if we're looking for a certain pathology, and it can really further detect our treatment strategies and operative planning. Some potential limitations of this study showed that even though that they were selecting for patients that were had the disease, they didn't really have an adequate control group. So just something to keep in mind.
Yeah, great job presenting that study as well. So I think this was a great study. Even back in '93, this is when MRI was still not widely used and CT arthrograms were being used, and I would say that is now definitely a thing of the past. And this sensitivity and specificities kind of stand true. You'll see a lot of practitioners still just ordering plain MRI imaging for the shoulder, but you'll also see a decent amount ordering the MR arthrography, so putting dye into the shoulder, which does tend to be a little bit more sensitive, but this can still be seen with pretty good sensitivity even on an MRI without contrast in there. So great job.
Yeah. In my experience, I think the arthrography, it'd be interesting to repeat this with higher powered MRIs and everything, though I wonder how to get by an IRB now, these days with multiple imaging modalities, CT scan, all that stuff. Um, but most people are moving away, to my knowledge. I don't know. It just seems level like 7 evidence that um, you know people are moving away from arthrography because the imaging quality is a lot better now. And one, again, people aren't going around searching for slaps in a general practice that much now. Might be more useful in your laborer, certainly high level athlete who does have that slap classic pain, but the arthrogram can be painful to people, or at least uncomfortable. And once you have a dislocation, people refer to it as an auto arthrogram, where the shoulder is already pretty swollen, so that fluid will light up and show you that labral tear quite easily. And this is particularly for that Bankart lesion. I'm not particularly sure about the slap tear, but I haven't found an MRI with a degenerative shoulder where the radiologist hasn't said at least possible slap tear.
Very true. All right, we'll move on to the next article.
Yeah, looks like I'm next up. So this was a paper by Burkhart, Morgan, Kibler out of arthroscopy in 2003. Specifically, this was looking at the disabled throwing shoulder, spectrum of pathology, part 2, evaluation and treatment of slap lesions in throwers. Next slide over there. It's a clinical review and expert opinion article. Authors pretty much sought to establish general guidelines and understanding regarding the disabled throwing shoulder, specifically looking at underlying biomechanics, pathoanatomy, kinetic chain consideration, surgical treatment, and rehab protocols. Essentially, this is kind of like a 3-part series that they put out over about 6 or so months. Pretty much the first part was looking at pathoanatomy, things like that. Part 3 is looking at more like scapular dyskinesis, kinetic chain rehab. And then part 2, which we're looking at, is specifically looking at evaluation and treatment of slap injuries. Authors, again, pretty much subcategories. Part 2 is physical exam, arthroscopy, what are you looking at, what are some of their techniques for treatment, and then their post-operative rehab protocols. For physical exam, it was kind of based on an initial study by Morgan back in 1998, where they looked at 102 patients undergoing type 2 slap repair with no anterior instability or associated Bankart lesions. They kind of correlated their findings to 4 preoperative physical exam tests to what they saw on the scope. Specifically looked at bicipital groove tenderness, Speed's test, O'Brien's crossarm test, and modified Job relocation test. Specifically, positive tests for bicipital groove tenderness is pretty self-explanatory. Positive Speed's test is anterior shoulder pain in the bicipital groove region when resisting forward flexion with the shoulder flexed at 90 and the forearm supinated. Positive O'Brien's crossarm test is anterior shoulder pain against resistance with the shoulder adducted and forward flexed to 90 degrees across the chest. And then a positive Job relocation test is shoulder pain and apprehension, specifically located posterior superior, produced by abduction external rotation that's relieved by a posterior directed force across the humeral head, which is different than like your apprehension sign to anterior instability. For them, they found that Speed's and O'Brien's tests were highly sensitive for anterior lesions, while Job relocation test was highly specific for posterior lesions. Arthroscopic findings. This is kind of based on a little bit by Burkhart, reporting a positive peelback sign. On the next slide, sorry, Sammy. When performing Job relocation test during arthroscopy, kind of associated diagram shows the kind of how the slap tear happens, or how it kind of looks like posterior directed force during the Job relocation maneuver reduces the labral subluxation. Some other signs or associated issues that they saw was like an unstable bicep superior labrum complex, would show like a superior sublabral sulcus over 5 millimeters, displaceable biceps root when probing, or also like a positive drive-through sign. So to test the drive-through sign is accomplished by sweeping the arthroscope from superior to inferior between the glenoid and the humeral head to see if it can be easily driven through the joint. And this is kind of associated with a pseudolaxity you see with slap lesions. And then performing the dynamic peelback maneuver in a shoulder with a positive or a posterior slap lesion will cause the entire biceps labrum complex to drop immediately over the edge of the glenoid, while anterior slap lesions often have a negative peelback test but have these other signs. 4 techniques: positioning, lateral decubitus position, 5 to 10 pounds of traction, arm in about 30-45 degrees of abduction, 20 of forward flexion. Typical portals, standard posterior, anterior portals, or more so anterior portal just above lateral border of the subscap, and then anterior superior portal just lateral to anterior lateral corner of the acromion. Fixation, they just talked about for resisting peel-back forces, a tight suture loop was critical to be positioned just posterior to the root of the biceps with the anchor placed beneath the root of the biceps. And then last, their rehab protocol was pretty much emphasizing passive range of motion in the early post-operative periods, specifically for people for anyone that got a posterior inferior capsulotomy, begin sleeper stretches on post-op day 1. For everybody else, they began this around 3 to 6 weeks after surgery. Around 6 weeks, they started their strengthening exercises for rotator cuff, scapular stabilizers, and the deltoid, and progressed from there. For people that were throwers, in this patient population, they can begin throwing at 4 months, full speed throwing at 6 months, and then full velocity from the mound around 7 months, and they continue sleeper stretches indefinitely. And some of the big conclusions from it. It was just a comprehensive protocol regarding management of SLAP lesions at this time. Suture anchors just posterior to the biceps root was crucial to neutralize peel-back forces. And then a tight posterior inferior capsule was believed to contribute to a pathologic cascade to a SLAP lesion, and recurrence of tightness can be expected to place the repair at risk in a throwing athlete. So that was what they went over in this.
Awesome. Yeah, great summary, Matt. Definitely one of the earlier papers, I think, looking at the specifics of a throwing athlete, how we mentioned earlier from Alex's paper back in 1990s when this was first being described, is that your laborer and your throwing athlete are very different patients, and the pathology and evaluation and treatment will differ as well. Moving on to our next article, looking at arthroscopic treatment of isolated type 2 SLAP lesions. So this was out of AJSM by a group, and they evaluated specifically looking at type 2 lesions. So their study design was essentially testing the hypothesis that biceps tenodesis offers a viable alternative to the repair, which at the time was the current standard of an isolated type 2 SLAP lesion. So again, we got into this a little bit, but when these were first described, the main idea was to try and repair these versus debride these, as opposed to cutting the biceps and then suturing it in place, which is a tenodesis. So their objective was to compare tenodesis to SLAP repair using the constant score, and then they analyzed subjective outcomes as well with patient satisfaction, and then they evaluated return of patients to previous level of sport. This was a single surgeon prospective cohort study. They had 25 patients ranging from 2000 to 2004. Their inclusion criteria was shoulder pain limiting activities. They needed to have failed 6 months of conservative treatment and then also have a type 2 SLAP on scoping. Exclusion, instability, rotator cuff rupture, posterior superior impingement, or previous shoulder surgery. Basically anything else. They wanted to just isolate these type 2 lesions and see what they could find. They had 10 men that had an average age of 37 that underwent SLAP repair with suture anchors, and then 15 patients, 9 men, 6 women with an average age of 52 that went in arthroscopic biceps tenodesis. The results, so they had an average follow-up of 35 months with a minimum of 2 years. In the repair group, the constant score improved from 65 to 83, with 60% of their patients being disappointed on their subjective evaluation because of persistent pain or inability to return to their previous level of sport. And then only 20% of those patients were able to return to the same level of sport. In contrast, their tenodesis group had a constant score again improved from 59 to 89, with 93% that were satisfied or very satisfied, and 87 were able to return to the same level of sport. And then of note, 4 patients that failed the SLAP repair actually returned and underwent a tenodesis and then had successful outcome, and they were able to return to their sport. Interestingly, they also showed a picture of their repairs. Again, if you're following along on the slide deck, the top image is their repair group, and the bottom image is their biceps tenodesis repair image. And this is another kind of interesting thing that has evolved over the years, is that at least from the classic way that I've been taught by a lot of my attendings, is that some of the issue comes with the biceps being unstable in these slap lesions, which again is why we've started tending towards doing a tenodesis. And what they were doing when they were first doing these repairs, they didn't have knotless suture anchors, or at least this group wasn't utilizing them. And they tacked it down right next to the biceps with huge long tails that I think could also be kind of already contributing to that irritation. And you can see on the image too that there's already some synovitis in that biceps attachment. So I thought that was interesting that that was published in their paper. In conclusion, though, they found that arthroscopic biceps tenodesis can be considered an effective alternative to the repair of a type 2 slap lesions. And this overall allowed their patients to return to a pre-surgical level of activity in sports. And essentially, they said that tenodesis may provide a viable alternative for a failed slap repair. Still kind of hedging their bets and not advocating for a full-on tenodesis for everything, and mainly saying, hey, we can probably fix these first, and if it fails, then we'll go to the tenodesis, which kind of shows the kind of treatment algorithm at the time. The limitations of this study, obviously, it was a small sample size. Again, they only had 25 patients. And the big thing was that they had differing age groups. So the slap repair group was 37 years old, and the tenodesis group was 52 years old. And that was actually chosen by the surgeon based on their age. So they favored to treat the patients who were younger with a repair in the thought that the tenodesis wouldn't perform as well. And the older patients, they preferred to do a tenodesis because they deemed it more of kind of an irreparable thing and to just go ahead and tenodese it and cut the biceps. And those patients actually tended to do a little bit better, which kind of leads us into our next study, which is talking about more type 2 lesions and looking at rotator cuff in patients over 50.
But yeah, so I had this study no advantages in repairing a type 2 slap lesion when associated with rotator cuff repair in patients over age 50. So you can go to the next slide here. This one was published in 2008 in American Journal of Sports Medicine. Basically, this is a randomized control trial evaluating patients with both a type 2 slap tear, which you kind of mentioned earlier is defined as labral fraying with detached biceps tendon anchor, as well as a rotator cuff tear. And so basically what they did was when these patients were taken to the operating room, a diagnostic scope was performed to confirm the diagnosis, and then the patients were randomized to have either a slap repair in addition to a cuff repair, or a cuff repair only with a biceps tenotomy. So the slap and cuff repair was group 1, and then the cuff repair with tenotomy was group 2. Their two main outcome measures that they looked at were the modified UCLA score and range of motion. So for the results, again, they had 63 patients, 31 were randomized to the cuff repair and slap repair group, 32 were randomized to the cuff repair and tenotomy group. They had a minimum of 2.9 years of follow-up, and 5-year results were available for 56 of the 63 patients. Pretty good mid to long-term follow-up there. When we looked at UCLA score, both groups improved significantly from baseline. Sorry, I think, Sam, this, if you guys are following along on the slide deck, this is not the updated slide, but actually the group 2, the tenotomy group, had a statistically significantly higher UCLA score compared to the group that had a slap repair and rotator cuff repair. And then same thing for range of motion. Both groups improved significantly from their baseline, but the group 2 with the tenotomy had significantly better range of motion postoperatively than the group that had the slap repair as well. So ultimately, the authors concluded that there's no advantage to repairing a type 2 slap lesion with associated rotator cuff tear in patients older than 50 years old. And that patients with rotator cuff tears and type 2 slap lesions who underwent biceps tenotomy had improved range of motion and function compared to those who underwent slap repair. And then this was a randomized control trial, and they had a really good follow-up, but there were some limitations of this study were similar to some of the other studies, just some of the potential heterogeneity. They didn't really talk about like the size of the cuff tear or the repair quality. All of the patients had intact subscaps, but they didn't go into how large the tear was, like how much fatty infiltration there was preoperatively, all things that could have also affected their outcomes if there was a difference between the two groups. They didn't include conservative management, and they also didn't include a tenodesis group, kind of purely comparing the tenotomy to a slap repair. And then again, even though it was a randomized control trial, it was still kind of a smaller sample size, which lends the study to be vulnerable to fragility. And they didn't do a power analysis, so we didn't really truly know how many patients they needed to basically claim that the results were valid.
All right. Yeah, great job summarizing that one as well. That is all we have for the Citation Classic. If anyone has any closing thoughts, speak up or forever hold your peace, I guess. Otherwise, thank you all so much for listening. Thank you to the team as well. And we will see you guys next time for our next Citations Classics Shoulder and Elbow edition.
Strong work, guys.